A very good morning and warm welcome. I myself, Dr. Anusuya V, Associate Professor from the Department of Orthodontics and Dentofacial Orthopedics, Vinayaka Mission Sankaracharya Dental College, Salem. Today I am going to take the class on management of crossbite. To begin with, Graeber has defined crossbite as a condition where one or more teeth may be abnormally malposed, buccally, lingually, labially, or with reference to the opposing teeth or a teeth. It is an abnormal occlusion in the transverse plane. So when we define the malocclusion, it could be in both vertical plane, transverse plane, or in the sagittal plane. But this crossbite malocclusion comes mainly in respect to the transverse plane, whereas in case of class 3, this comes in the anterior-posterior plane. If you see the basic classification, it can be based on the location or it can be based on the nature. Based on the location, if we see, it is the anterior crossbite, that could be again a single tooth crossbite or a segmental crossbite. Posterior crossbite, that could be again unilateral crossbite or bilateral crossbite. Based on the nature, again it could be a skeletal crossbite, dental crossbite, or a functional crossbite. If we see this diagram, we have diagram A here. If we see the diagram A, which is absolutely a normal relationship. As you can see over here, the lower molar buccal cusp is getting into occlusion with a central groove of your maxillary molar, whereas the buccal cusp of your maxillary teeth is more buccal, which we call it as a buccal overjet. Whereas if you see the diagram B, you can appreciate very well that in the right side, as I am making the arrow mark over here, the buccal cusp of your lower molar is quite out, whereas your buccal cusp of your maxillary molar is coming in, occluding in the central groove of your lower molar. So this situation, which is the abnormal position of your lower teeth in the transverse plane, as I have made the direction of a transverse plane over here, and this plane depict that the lower molar on the right side, which is totally out. Here the buccal overjet relationship is quite opposite to that of your diagram A, whereas we can see it over here, which is diagram C, where your both the sides bilaterally you can appreciate the lower buccal cuspid is totally out. Whereas in case of diagram D, as you can see, both your lower right as well as left side molars are directly in quite opposite relationship to your diagram A, that is your lower molars are totally entitled within the maxilla, and the diagram E depicts totally an opposite relationship to your diagram D, where totally both the lower molars are out. Maxilla is getting entitled inside the mandible. As we can go one by one, that is anterior crossbite, that is characterized by a reverse overjet, whereas the normal relationship of your maxillary incisors, if we see that there is a horizontal overlap of your mandibular incisors by the maxillary incisors, the normal overjet will be around 2 mm, that is what is called as normal. Whereas in case of your anterior crossbite, we term it as the reverse overjet. The reverse overjet is the mandibular incisor is quite out and they are covering your maxillary incisors. As we can see in the second line, mandibular anteriors overlap the maxillary anterior. It may involve again single tooth or the entire segment. Accordingly, we term it up. Again, we can see the diagram A, where you can appreciate one single canine, which is a 3-3, that is actually covering your two toe, that is maxillary left lateral incisor is getting overlapped by your mandibular lateral incisor, which is on the left side, as well as the canine, which is on the left side. So this condition is known as single tooth anterior crossbite. Also we call it as a reverse overjet in this area. Whereas the B is again depicting or 2-1, which is upper permanent left central incisor, that is getting covered, overlapped by your lower central incisor on the left side. Whereas we see the diagram C, which is known as a segmental anterior crossbite. What happens over here? You see the diagram A and B, where only one single tooth is getting overlap. Whereas in case of diagram C and D, from the canine to canine, that is the entire anterior segment that is overlapping. The lower anterior segment is overlapping upper anteriors, as well as you can see it over here. There is a midline diastema. As you can see, there is a gap between your 3-1 and 4-1. Whereas if you see the diagram E and F, this is the typical example that we observe in case of your posterior bilateral cross bite, which happens whenever there is a thumb sucking habit. Due to the thumb sucking, you can appreciate here the maxillary anteriors are getting proclined and the entire maxillary arches is getting narrowed. That causes posterior bilateral cross bite. Whereas in case of your diagram G and H, you can see it over here. There is presence of tongue that can be appreciated as here that I am marking, and there is a midline diastema. Maxillary incisors are getting flat, as well as there is a spacing in case of your lower dentition, gap between canine, premolar, as well as some amount in case of your anteriors. Along with that, there is a reverse overjet relationship. With this, the entire maxillary arch is inward, that is inside, compared to your mandibular dentition. Typically a case of a maxillary deficiency or mandibular prognathism, such as kind of a Down syndrome, they will be representing a situation like G and H. So as I said, the posterior cross bite, it can be characterized by abnormal transverse relationship. Again I emphasize the word transverse over here. That is, the cross bite that happens in the posterior region is typically in the transverse plane, whereas in case of anterior region in the anteroposterior or sagittal plane. That happens between upper and lower posterior teeth, and it occurs as a result of lack of coordination in the lateral dimension between upper and lower arches. So the lateral dimension between upper and lower arches, it says that the arch width, that is the transverse dimension, intermolar, intercanine, interpremolar width, when the arch width are relatively less in maxilla or more in mandible, we have this kind of posterior cross bite. So it can be again unilateral or it can be bilateral. And we have other kind of different technical terminologies for the same situation. We have something called buccal non-occlusion. In this, we have this maxillary posterior occlude entirely in the buccal aspect. It is also known as scissor bite. The same buccal non-occlusion, if it happens only on either a single tooth or in the multiple tooth on only one side, it is known as scissor bite. Whereas the same situation happens bilaterally, then this situation is known as Brody's bite. So the next situation is known as lingual non-occlusion. Lingual non-occlusion, this is a form of posterior cross bite where the maxillary posteriors occlude entirely on the lingual aspect. As the word we can remember like this: the buccal non-occlusion, the maxillary posterior totally buccal to the posteriors, whereas lingual non-occlusion, maxillary posteriors are totally lingual to the mandibular posteriors. Next is that based on your skeletal base, that is skeletal cross bite. It occurs as a result of malposition or malformation of your jaws. The typical example of this would be your skeletal class 3 malocclusion. What happens in skeletal class 3 malocclusion? Your maxillary jaw, that is your anteroposterior length as well as the width of your maxillary blades could be deficient in comparison to your mandibular jaw, that is your lower jaw. Usually this would be an inherited result from your defective embryological development, or also could be a excessive mandibular growth due to a syndrome or familial tendency. And this skeletal posterior cross bite usually characterized by your narrow upper arch. As you can see in this diagram A, B, C. Here we have this portion which is a cranium, and this portion is known as your maxillary base, that has been depicted in the slight peach color. Then we have your white portion in the maxilla, which is your maxillary dentition. Then we have your mandibular dentition and we have your mandibular jaw base. So we have almost 5 portions that has to be related to each other. Whereas the cranium to the maxilla, maxilla to your maxillary dentition, maxillary dentition to your mandibular dentition, maxillary jaw base to your mandibular jaw base. So, in the diagram A, if you see that your maxillary dentition is quite away as well as your mandibular jaw is quite out from your maxillary jaw base. Whereas in the diagram B, this relationship is mainly contributed here due to the excessive growth of both mandibular jaw base as well as mandibular dentition. Whereas in the diagram A, it is due to your deficiency of your maxillary dentition as well as maxillary jaw base. As you can see the diagram, see over here. The cranium is present, mandibular jaw is present, maxillary jaw. If we see here, the deficiency is contributed to the combination. Combination means there is a deficiency in maxilla as well as there is an excess in case of your mandibular jaw base. When the teeth is placed over the excessive mandibular jaw base, by default it has a tendency to have proclined mandibular dentition. The same way deficient or retroclined maxillary dentition. So, we have the situation which is A, problem is at maxilla, whereas the situation B, problem is at mandible, whereas situation C, where we have a combination which has a problem in both maxilla as well as mandible. Whereas the dental crossbite, this is based on only the dentition. The word itself suggests that dental crossbite, that means your skeletal jaw bases are absolutely normal. What happens here? It is basically a result of your localized disturbances. Localized disturbances such as your ectopic eruption of permanent teeth, over-retained deciduous teeth, and the specific situation known as TSLAD, that is your tooth material arch length discrepancies that can result in either crowding or lingual positioning of your upper teeth that will lead to your dental crossbite. Whereas the functional crossbite. Functional crossbite is here, your jaw bases are good, your dentition is good, but when positioning your jaw from CO to CR, we know CO, right? That CO is centric occlusion, CR centric relation. From the rest position, when the jaw moves, mandible moves and get into the maximum intercuspation, then comes this functional crossbite. There is some kind of occlusal interferences. This is the key over here. The keyword is occlusal interferences. This is going to result in deviation of mandible during the jaw closure, resulting in unilateral posterior crossbite. The habitual forward positioning of mandible, otherwise also known as it is a pseudo class 3. It may lead to an anterior crossbite. So, in case of functional crossbite, it is due to the hindrances or the interferences produced by one or other teeth that deviate your jaw to either right side or the left side or anteriorly before closure. That leads to crossbite. So, if we see the etiology, almost altogether to put all the previously seen points in a line, that is narrow upper arch, that leads to a decreased growth stimulation in the mid-palatal suture. Collapse of maxillary arch, as we can see in the congenital defect like cleft lips and palate. Then comes your sagittal discrepancy such as your forwardly placed mandible or deficient maxilla or combination of both, or unilateral hypo or hyperplastic growth of any of the jaw. If it is a hyperplastic growth of maxilla, hyperplastic growth of your mandible, or again the combination of both. Then the persistence of permanent tooth, that is single tooth crossbite. Here if you see the overlonged retained deciduous, that leads to this single tooth crossbite. And then crowding and abnormal displacement of one or more teeth, presence of any habit such as I told, it is the thumb sucking, that leads to molding of anterior portion of your maxilla. In that situation there will be bilateral posterior crossbite and the retarded development of maxilla both in sagittal as well as in transverse direction. So, that could lead to either anterior or posterior crossbite. Next we move on to the treatment of anterior crossbite. If you see this anterior crossbite, again we can divide before moving on to the treatment as developing crossbite or developed crossbite. Developing crossbite, that happens in mixed dentition period, that is your tooth is still in the eruption state. When the tooth is still in the eruption state, during that time if you are going to treat, then that is the use of the tongue blade in case of developing crossbite. Developing single tooth anterior crossbite, this is the very easiest one to correct. Here all we have to do is just use of your eye sticks or the wooden sticks or otherwise known as a tongue blades. Whenever there is a sufficient space and the tooth is still developing, you observe the case in case of your mixed dentition period. Then all you have to advise is that take the tongue blade, keep it parallel to your developing tooth which is in the crossbite, that is in the palatal aspect. Then keeping the pressure over there for at least 2 weeks. This procedure will simply and easily bring the palatally placed single tooth more buccally. When the tooth comes more buccally, the crossbite is getting corrected automatically. So it usually be placed in the mouth contacting the palatal aspect of a tooth which is in the crossbite. That pressure which is applied from the palatal side, from the tongue blade, that is going to help in correction of this crossbite. But the disadvantage of this method is that the patient has to get a good amount of compliance. Patient should be very cooperative, otherwise this procedure will fail. The next step is again the Catalan's appliance. When the patient is not cooperative, a very young patient who is unable to understand what we are trying to say, then what we can do, we can take an impression of that particular patient. From the lower anterior region, we can construct a acrylic bite plane. This acrylic bite plane is designed in such a way that it has an degree of angle of around 45. That will guide again from the palatal aspect of your developing single tooth which is in crossbite. Slowly due to the eruption force along this angle, the tooth will come more buccally and your crossbite will get corrected. So this is indicated when adequate amount of space is existing in the arch for the alignment of your crossbite. But again the disadvantages. If you see the disadvantages of Catalan's appliance, the main problem is that this kind of a acrylic bite plane which is placed over the lower anterior segment, that leads to your difficulty in speech as well as difficulty in your diet, that the patient cannot chew on your hard food, that they have to be fed with only semi-solid diet. And the another very important aspect is that whenever we use this Catalan's appliance, the patient has to wear at least 6 weeks or more, and if it has been to be worn at least for 3 months, then the problem with that is it will lead to a supra-eruption of posterior, as because this Catalan appliance act as an anterior bite plane. That leads to the supra-eruption of posteriors that will cause open bite. So again the open bite is another important side effect that might happen. We have to be very careful in case selection. We cannot use this in all the patient, and this appliance require frequent re-cementation. The next is your removable appliance of choice. We all know what is Z-spring, also known as double cantilever spring. So the action of double cantilever spring is to treat one or more teeth to produce the labio-lingual tooth movement, as Z-spring is going to produce your especially this labial tooth movement. This is going to correct or cross bite in the anterior segment. The next is your growth period. So whenever there is a developing cross bite, that is growth period, as you can see it is your skeletal cross bite. The skeletal means your maxillary jaw is deficient. When the maxillary jaw is deficient, that is your skeletal anterior cross bite that is occurring in the growth. We have a chance of growth modulation. So as it occurs as a result of your retroposition maxilla, it should be treated before termination of growth. So we have an excellent appliance which is called Petit face mask. The Petit face mask is a reversible headgear. Also it is by using your protraction of your maxilla. It is happening due to the reason all your sutures are tender at early age before they get completely ossified. It is easy to use your reverse pull headgear in order to increase the growth of your maxilla. The same way, if the problem is going to happen in case of your mandible, this excessive mandibular growth should be intercepted from your chin cup, whereas the fixed appliance for treatment of your anterior crossbite. We have crossbite elastics. Though we have a different kind of modalities to treat in the fixed appliance. This is like multi-looped arch whereas we can use, or we can use transpalatal arch, which is a modified one, modified TPA, as well as the expansion appliances using your different kind of expansion appliances such as quad helix, but still as such to say it is the crossbite elastics. So the crossbite elastics, if you see, it involve the molars that are treated using your elastics. This is basically stretched between your maxillary palatal surface and mandibular buccal surface. Again, to remember, this elastic is going to work on both the molars, that your maxillary molars are going to come outward, whereas your mandibular molars are going to go inward. So if suppose you find fault only in your maxillary arch which needs to be expanded, better not to choose your crossbite elastic. This is used only in case of single tooth crossbite. If you really want to expand your maxillary posteriors, better to go for your expansion appliances rather than your crossbite elastics. And sufficient space is very important in order to use this elastics. And whenever we use elastics, it should be worn both day as well as the night time. And important side effect to consider in mind is that extrusion of the teeth. Any mechanism which you try to use for longer time period, that is going to cause extrusion of your teeth. And another important appliance over here is your coffin spring from the removable appliances. So this consists of an omega shaped wire. If you see this omega shaped wire, it is kept in the mid palatal region having an acrylic plate and activated by means of expanding this. This is going to produce only the dentoalveolar expansion. So if you have to choose your mild to moderate cases, and that needs only maxillary expansion and a mixed dentition period, then only you have to think about choosing this coffin spring. The quad helix, again we know that this is an expansion appliance. It has 4 helices capable of dentoalveolar expansion only. So your case selection is very important over here. Which case are you going to choose for this kind of expansions? Is there a problem only in the maxillary dentition? Posterior needs to be expanded, or you need to have your skeletal expansion also. In case of your skeletal expansion, the quad helix can able to do only in the young patients. The early transition of your mixed dentition period or your deciduous dentition period alone, not in case of your permanent dentition or your growth completed patients. So what do we have to do in case of your growth completed patients? We have your rapid maxillary expansion. This rapid maxillary expansion could be done from your mixed dentition period to your permanent dentition. Here the bilateral skeletal posterior crossbite characterized by deep palate as well as the nasal obstruction, narrow maxilla, all these 3 things can be corrected together by just a rapid maxillary expansion. What happens here is the mid palatal suture present between 2 halves of your maxilla, that is going to split and expand. So we have n number of rapid maxillary expansion appliances to do that. We have a broad classification to say that tissue bone or a tooth bone, whereas Hyrax is going to be used as a conventional and routine manner. When it is done using the appliances where we use a screws, the Hyrax screw which is used for your rapid maxillary expansion, again comes in different dimensions. Based on your severity we can choose that, and the activation protocol again is going to change depending on your age, depending on your amount of severity. And another removable plates which we can use is like a split acrylic plate, jack screw, Adams clasp and the posterior teeth to retain it in the palate. If you see this is a simple expansion plate, Hollies with jack screw, that can be used in order to produce 1 or 2 single tooth posterior cross bites. So we have seen all these kind of different appliances so far. Now here to have a small recap of the management of crossbite, as I would like to say it again, that crossbite could be of different category. We have anterior or posterior. In anterior we have single tooth or segment. Posterior again we have single tooth or segment. Based on the tissues again we have dental crossbite, skeletal crossbite or functional crossbite. And if you see this different terminologies has been used, we have buccal non-occlusion, lingual non-occlusion. Buccal non-occlusion, if it happens bilaterally, it is known as Brody's bite. And this crossbite is a typical scenario seen in the transverse plane. That is, the posterior buccal crossbite is seen in transverse plane, whereas anterior crossbite is seen in anterior-posterior plane. And we have seen a different kind of situations over here. And if you see the treatment for the same, we have dental, we have skeletal and we have functional. The dental, based on your etiology, if the problem is your retained deciduous, then we need to think about extraction of your retained deciduous, create adequate kind of space. And if the space is adequate enough, then we have the options, that is your developing or develop the crossbite. After verifying whether it is developing or developed, in the developing crossbite we have two options. One is use of a tongue blade therapy, the second is use of Catalan's appliance. And if it is a developed crossbite, that is anterior single tooth crossbite, then we can start from your removable appliances. If you see the removable appliances, for case of your single tooth anterior, we have your Z spring or double cantilever spring. We can also use your single cantilever spring, cranked cantilever spring to some extent in order to produce the same labial movement of your tooth. Also, we can use your segmental modified Hollies with jack screws in order to correct. Whereas in case of your canine crossbite, then we can use your palatal canine retractor in order to correct your palatally positioned canine, which needs to be corrected for a crossbite. But in case of your posteriors, such as your premolar or your one molar is in crossbite, we have something called T-spring. The T-spring is used for the correction of your palatally positioned premolar or your single molar. The same way expansion that is done with the TPA, transpalatal arch, is also used for the correction of your single tooth crossbite in case of your molar region. Then next comes is your growth period. During the growth, if we have this skeletal problem, then we need to think about your growth modulation. Before starting with this growth modulation, we should again classify the problem: maxillary deficiency or mandibular excess or combination of both. Maxillary deficiency, we need to use protraction face mask in case of maxillary deficiency, or it is also known as reverse pull headgear. In case of mandibular excess, we need to use our chin cup in order to restrict the growth, or in case of combination, the same petit face mask can also do the work. That this petit face mask is going to protract the maxilla. Also, the chin cup which is placed in case of your petit face mask is going to restrict the growth of your mandible. Whereas moving on to your fixed appliances, the variety of your expansion appliances are coming to play the role, as well as the use of different kind of elastics. The main elastics to remember here is crossbite elastics. but the crossbite elastics should be used when there is both your mandibular teeth has to come inside, maxillary teeth has to go outside. Single arch effect should not be utilized with the help of crossbite because it is going to affect both maxillary as well as mandibular teeth. And we have a few kind of expansion appliances. When it comes to expansion, we have dentoalveolar expansion and we have skeletal expansion. In dentoalveolar expansion, we have your coffin spring, we have W arch, and we have quad helix as well as the Hollies with jack screw. All these four kind of appliances are going to produce your dentoalveolar expansion. And the skeletal expansion, we need to use this rapid maxillary expander. The rapid maxillary expansion is going to split your mid-palatal suture, going to correct the skeletal jaw base of your maxilla, going to expand the skeletal jaw base. Definitely this do have an effect on your dentition, but it is like 50-50, majority in the skeletal expansion. This can be again categorized into tooth bone or tissue bone. The screws which are used comes in multiple dimension and different kind of protocol according to your case selection. This removable plates which is modified can be used in other way to correct single tooth in the posterior region or premolar region to correct the cross bites. So hopefully I have summarized the entire presentation. Thank you for watching.